Rational fluid and volume therapy. Acute blood loss during surgery triggers hypovolemia and hemodynamic instability with escalating clinical consequences. Severely reduced circulating blood volume may lead to lower venous return and lower cardiac output, which may cause hemodynamic instability. Compensatory physiological mechanisms include vasoconstriction and redistribution of blood flow. However, persistent bleeding reduces organ perfusion and impairs the delivery of oxygen to the tissues. Further induced pathophysiological processes may lead to irreversible organ damage and organ failure. A key goal of perioperative patient management is to ensure early and adequate treatment of blood loss. It's tailored to restore and maintain effective circulating blood volume, support macrocirculation, and maintain microcirculation. Two types of intravenous solutions are normally used to correct hypovolemia. Crystalloids, made of water and electrolytes, replace extracellular fluid losses from perspiration and urine output. Colloids, or macromolecular solutes, such as modern tetrastarches, offer ideal plasma volume expansion. Let's simulate intraoperative fluid resuscitation with crystalloids to manage acute blood loss. Our 65-year-old male patient is scheduled for routine open colorectal surgery. Apart from concomitant hypertension, he's otherwise healthy. A TIVA, TCI, and routine monitoring will be used with an additional central venous and arterial line. During surgery, the patient loses 1 liter of blood, which is replaced by 2 liters of crystalloids in combination with vasopressors. Hemodynamics are not fully restored, and the patient still suffers from hypovolemia. Consequently, even more crystalloid infusion is required. This replacement scenario might result in fluid overload, tissue edema, and impaired outcome. Although a pure crystalloid regimen for volume resuscitation is possible, it might not be the best solution. Due to their physiological properties, crystalloids are distributed over the entire extracellular space. Their intravascular volume effect is approximately 20%. Which means their duration of action and the time they remain in the vessels is only short. Therefore, a larger amount than the estimated intravascular deficit must be administered using crystalloids. This increases the risk of fluid overload, the development of interstitial edema, and post-operative weight gain. These factors may lead to more post-operative complications and increased mortality. Concomitantly administered vasopressors inducing vasoconstriction may impair microcirculation and compromise tissue blood flow and oxygen delivery. Both intravascular hypovolemia and fluid overloading are harmful to the patient. How can volume management be optimized in order to keep the patient normovolemic throughout surgery? Let's repeat the simulation using a colloid. In this case, an isooncotic hydroxyethyl starch 130 to replace the intraoperative blood loss. Following blood loss, 1 liter of hydroxyethyl starch fully restores hemodynamics. Hydroxyethyl starch produces faster and more effective hemodynamic stabilization than the crystalloids, with the potential to prevent fluid overload and reduce vasopressor requirements. Due to their molecular size, colloids are retained at the vascular barrier and remain in the intravascular space. Therefore, their volume effect is approximately 100%, providing the vascular barrier is intact, and they're suitable for replacing blood loss at a 1-to-1 ratio. Colloids are thus better at restoring cardiac preload than crystalloids following acute blood loss. The use of hydroxyethyl starch results in better hemodynamic stabilization, despite using much less fluid. Microcirculation is consequently also preserved. A careful distinction must be made between indications for crystalloids and colloids. Crystalloids should primarily be used to replace fluids such as body water and electrolytes, whereas colloids can more quickly and adequately compensate for reduced circulating blood volume. Hydroxyethyl starch should be an integral part of rational and successful perioperative volume management. It may be more favorable than the use of crystalloids. In cases of acute blood loss, compensation with hydroxyethyl starch provides superior hemodynamic stability and can reduce the risk of fluid overload. It's the most studied colloid with proven efficacy and safety. Voluven and Volulite can make a difference to patient outcome in surgery.